Well, good afternoon. My name is Paul Sternberg. I'm a retina specialist and ophthalmologist at Vanderbilt University in Nashville, and I'm also the president-elect of the Academy. In addition, at Vanderbilt, I have some administrative responsibilities that go beyond ophthalmology. I'm the chief medical officer for the Vanderbilt Medical Group, which means that I oversee our physician practice plan. So this afternoon I've been asked to talk a little bit about healthcare reform and about how I think it will be affecting ophthalmology and specifically retina because I'm here in Las Vegas for the meeting of the ASRS, the American Society of Retina Specialists. And obviously there are a number of retina specialists who have anxieties and concerns about how these changes that we see will be affecting them. And I guess we should start by why is there healthcare reform? What is driving the passing of the Accountable Care Act and all the changes that we see in our community, some of which are specifically linked to the ACA and others that seem to be either running ahead of it or being pulled by it. And quite honestly, the main reason is the increasing cost of healthcare in this country. That if you look at the cost per capita in the United States, if you go back to the 1960s, it was around $150 a person, and by the 1970s it was around $500 to $600 a person. Now it's running about $8,000 per capita. That's far outstripping the growth in any of the other economic indicators. And projecting forward, they see it going well into above $10,000, $12,000 unless some changes are being made. So we have this rapid and steady increase in the cost of health care, and at the same time there's been a flattening of our economy as a whole. So those two things together mean that health care is assuming a larger percent of the cost of all the costs in this country, somewhere around 1/5, I think now. It's going to hit. It's currently at 1/6, maybe 1/5 of the expenses. And that's not sustainable. It simply is not sustainable. If you look at the growth in earning power over the last few years, there really hasn't been very much among the average income of Americans, and a lot of that flattening is due to the increased amount of their income that they're paying towards health care. And on the other side of the coin, people ask, are we getting our money's worth with this increased cost of health care? How are we faring? And although we have an amazing health care system in the United States, the opportunities to get great care, the innovation and that stems from our healthcare industry on the major indicators, the mortality rates, they really are not at the top of the world like our costs are, and that's concerning. We talk about there being a lot of our poor health being linked to obesity and smoking, but those problems are present elsewhere. So we really have to figure out ways to provide better health care with costs that don't continue to increase, and that's what's driving healthcare reform. Now, from my perspective, you can either have it done to you or you can do it yourself. So I think a lot of what myself and David Park and others who are active in the Academy and in the ASRS are trying to message to our members is that we want to encourage you to both gain knowledge and become active in identifying ways that you can stay ahead of the curve yourself. And there are a lot of different things that are coming out of the Affordable Health Care Act and the general health care reform environment. You've heard about ACOs, and ACOs are a specific mechanism that has been identified, originally described by Elliot Fisher in Dartmouth, where providers get together. They're specifically contracted through the government, and they have shared risk for a population of patients, and part of their ability to achieve highest payment is based on improving quality and safety, and as well as service. And all of those are very enviable, and I think we all strive for that and should continue to do so. But the ACO does have some fairly strict guidelines around it. And when you really look at it and how ophthalmology plays into it, it's driven more around primary care, around the leading causes of morbidity in this country, hypertension, congestive heart failure, COPD. And ophthalmology's a bit at the periphery of it. Whether ACOs really will take over, it's hard to say. I tell my patients, I kind of had to turn in my crystal ball when I got my medical degree. But I think that something like it is certainly going to exist, and in some of your communities, there may already be active ACOs that are asking you to consider being involved. An alternative to ACOs are what we call CINs. It's clinically integrated networks. And these have a similar concept to the ACOs, but are a little more flexible. Clinically integrated networks are where providers get together, where they will go to employers or payers to provide services, but the reimbursement may be more on a fee-for-service basis as opposed to a totally shared risk, that the setting of the quality and safety indicators can be more done by you internally and less by external forces. And your obligation to participate in this one network may not be as rigid as you may see with ACOs. But I think largely in ophthalmology, again, because we are a little bit more peripheral, there are other things we can do to make ourselves preferred providers. I think you need to think about innovative ways that you can do that. In retina, for example, there are certain things we do that do potentially cost payers a lot of money. One may be the care for wet macular degeneration. Another may be care for patients with diabetic retinopathy. And those of you that are general ophthalmologists, obviously cataract surgery is costs, glaucoma. There are a lot of chronic conditions that we take care of and that can absorb a significant amount of the healthcare cost in your community. So if you can demonstrate ways that you can reduce those costs, whether it's a bundled payment means that you get paid a fixed amount for an episode of care. So that might be repair of a retinal detachment, that you're going to accept a finite amount of money to fix that retinal detachment, and that would include reoperations. So you'd be taking on the responsibility for perhaps not being paid if there's a reoperation, but if you know from your practice that you have a very low reoperation rate, that you're able to do those procedures, whether it's in your own ambulatory surgery center or whether it's doing some of those procedures in your office, you may be able to very successfully do that. Another may be for diabetic retinopathy. A lot of the cost for the care of diabetic retinopathy is in ancillary tests. Some practices order a lot more fluorescein angiograms and OCTs than others. And perhaps if you rely a bit more on your own examination skills and become a little less reliant on ancillary tests, you can significantly reduce the amount of cost for the care of those patients. And those are patients that need to be cared for in any sort of group care environment. Diabetics are a significant area of our population, ever increasing. And if you can demonstrate that you provide quality of care at an affordable rate to the big providers in your community, they're going to want you there. They're going to want you as part of their team. And then I guess the third thing I'd want to talk about is the insurance exchanges. The insurance exchanges are something that has been proposed as part of the Affordable Care Act. It's a way to provide somewhat more affordable health care to populations of patients that either don't have any coverage at this point or to get more affordable coverage. And insurance exchanges are an opportunity, but also a risk. The opportunities are that these are patients that many of you may be providing care for with little to no reimbursement. And so if you become providers for those insurance exchanges, you may get paid for services for which you were previously not being paid. That's certainly an opportunity. On the other hand, many of these patients have higher degrees of morbidity. are sicker patients, and they may absorb a significant amount of your practice resources, and you have to be sure that you can provide the care for a reimbursement rate that probably is going to be lower than what you're getting for commercial payers, and may even be lower than what you're getting at Medicare rates. So you have to very carefully know your practice and be able to provide care at a rate that's reimbursed appropriately through these insurance exchanges. There are other opportunities for innovation, and I think it's important that you continue to think about those. One that we've been looking at is what we call diagnostic management teams. For a disease diagnosis like uveitis, how do we make sure that we're doing the right tests for that patient? Sometimes we have a tendency to do a shotgun of tests when we see a patient with an unknown diagnosis. And we may be able to be more precise and order just the tests that that patient needs, and not a lot of unnecessary ancillary tests that drive up the diagnosis. Imaging is another area. How do we make sure that we order the right imaging study for a patient that might have a neuroophthalmic condition, double vision, something like that? We need to use those resources appropriately. So as I look down the road and think about healthcare reform, there certainly are drivers that are requiring it, and I think that we would be really putting our head in the sand if we ignored all the warning signs that the cost of healthcare is too high, and that in some areas the results that we're getting are not justified by the large expense. We have to think about that and prepare our practices and our own way of providing care with those concerns in mind. Never do we want to deny care to patients that are needing them. And I think one wonderful thing about our profession, about all of you, is that you do put the patient first. That's why ophthalmology is such a high consumer rating among people that do come to us. But we have to be thoughtful, and we have to be proactive and not reactive. I think we have a great opportunity to be people that set the pace for how we can reform eye care in a way that's cost sensitive, but also provides a high level of service and great outcomes for our patients.